So let's move to the goals so that we can put a little bit more of flesh. But before that, we need to specify the boundaries and the actors. And then when we talk about the actors, it will be obvious that who are those actors that may disagree on the goals. So we're going to start with the very first question. What is a health system? What are the boundaries? What are the actors? What are the major relationships? What is a health system? Well, at the most general level, the health system is the vehicle for the organized social response to health conditions, right? And as I just mentioned, it can be thought of as a set of structured relationships between populations and institutions. So what are those actors? What are those populations and institutions? For the first question of the boundary, I'm getting good at this. For the first question of boundaries, we saw the complexity, right? I mean, how much of this is inside the health system, the healthcare system, the determinants? Where do we draw these boundaries? The first thing to say is these are dotted lines. Do not think that these are, airtight boundaries. These are arbitrary boundaries, okay? Like all conceptual frameworks, they simplify reality. They are good to the extent that they are useful for action and to the extent that they are internally consistent. I mean, what you cannot do is, in the morning say that the education of girls is a determinant and then in the afternoon say that it's part of the health system. You have to be consistent and you have to have a rigorous way and an organized way of drawing those boundaries. But the boundaries are arbitrary. So, and you can redraw them on the basis of what you actually need to do. Because remember that the premise of this course is that effective action requires rigorous thinking. So if thinking becomes not rigorous but rigid, then it doesn't lead to effective action. It actually paralyzes you because you're saying, is this inside or outside? That's not the issue. The issue is how do we think in a more or less rigorous way so that issues like accountability can be sorted out in a clear way. So in the framework for the World Health Organization 2000 report, the World Health Report 2000, we introduce that the fundamental notion is the concept of health action, okay? Health action is the key concept to draw the boundaries. And you will remember when we went through the determinants of health that at the end we say, well, here's a health system, and then we try to draw the health actions through which the health system operates at multiple levels of that chain of hierarchical multi-causality. So it's the health action. And the health action is defined by a criterion. The key criterion here is a criterion of primary intent, okay? So the boundaries are determined by those health actions whose primary intent is what? What should be the primary intent of a health action? The primary intent. Improve health. Okay, that's the defining goal of the health system, is to improve health. And therefore, any action that has the primary intent of improving health, we define as a health action. Now, what's the virtue of this criterion? It is a middle of the road solution to these problems. It is much broader than health services narrowly defined. Everyone agrees that, visiting a doctor, going to a hospital visit, undergoing a surgery, taking a vaccine, the primary intent of all of those actions is to improve health. That's the healthcare system in the narrowest way. At the other end, at the opposite extreme of this continuum, we know that education, especially the education of girls, is a huge determinant of health, their own health and the health of their children and the health of the family. But when a girl goes to a school, is the primary intent to improve health? No, the primary intent is to educate the girl. So it doesn't include within the health system the determinants. Now, we will see that there is a very important function called stewardship. We will see that later today. That, among other things, includes mobilizing other policy arenas that act on the upstream determinants of health. But a determinant of health is not necessarily part of the health system. But then we have a number of gray areas. Clean water and sanitation. You know, in most countries of the world, in the vast majority, the provision of clean water and sanitation is not within the responsibility of health agencies like, you know, the Ministry of Health or the Department of Health. It's, you know, other entities. And we usually don't put that within the health care system. But the primary intent of bringing clean water is not so that, you know, people can go and fill their swimming pools. It's not for recreational purposes. It's a health intent. So you would actually classify that as a health action, even if it's not within the administrative boundaries of the healthcare system. Motor vehicle safety, you know, wearing of seat belts and regulations to force people to wear helmets in bicycles and motorcycles. The primary intent of all those actions is to improve health, to avoid injury or death, okay? So you would include that, or, you know, measures to protect pedestrians, okay? All of those actions which are in this gray zone, which no one would count within the health care system, but when you analyze and you say, why do societies introduce these measures or regulations or you know, even legal requirements, the primary intent is to improve health by preventing either injury or death, okay? So this is a definition that does not take the particular administrative configuration of a country as the starting point. So independent of which agency in a government, or whether it's a non-profit entity or a for-profit entity, that's irrelevant. If the sole criterion is the primary intent to improve health, then it is a health action, and that's then part of the health system. Okay, so if within those boundaries, this intermediate level, what are then the actors and relationships? And this is a diagram that's in one of your readings, and it was, you know, meant exactly to capture this relational view of health systems. So we've said that health systems are fundamentally a relationship between a population and a set of institutions that are populated also by people. Health systems are all about people, by the way. It's all about people. There's a group of people who we call the population, but these are, you know, people like us. And then there's, the institutions are actually populated by people like us, right? Health personnel, we're going to call them. Now, none of these exist, you know, in a sort of wild state. They're all organized. The population is organized at multiple levels. The most basic level of organization is the household. They organize in communities. Then they form trade unions, political parties, all kinds of organizations. Health personnel are also organized in their immediate organizations, their hospitals, but they form, you know, the American Medical Association, the British Medical Association, the nursing associations, you know, all kinds of groups. And the relationship between the two of them is these two main set of actors is usually not direct, but is mediated. There's a collective mediator. Now, previously, there have been other collective mediators, like, you know, the church or religious institutions were sometimes a mediator that organized some resources here and organized the population so that this relationship between population and institutions could happen. But in modern societies, almost invariably, the main mediator is the state. Enterprises have also been, by the way, mediators. You know, very early forms of health systems they were enterprise-based, so the company became the mediator. But in modern societies, the preponderant mediator is the state. I am using the state here in a narrow sense. It's basically, think of it as the government or the public sector, okay? Includes the government and then public or quasi-public entities, okay? There's a larger definition of the state as the political organization of a society, including the citizens, but we're gonna take a narrower view of the state mostly as public, the public sector. And then there are a number of exchanges that happen between the two main elements. The collective mediator, the state, relates to health personnel by exercising different levels of control, different degrees of control. And we will get into what determines the degree of control. The degree of control is basically how many functions of the health system that we will see in a moment does the government perform itself, okay? And the more functions the government performs, the more control it has over the providers, the health personnel. So if a state is directly providing care and owns the facilities and employs the doctors and nurses, that's the highest level of control. If you have a state that only sets very basic rules in which private entities can participate in the delivery of services, that's a least level of control. With respect to the population, the state, and if it's a democratically elected state reflecting societal values, this is what we're going to talk in a moment, determines the basis of eligibility of different groups in the population to health services, and we will see that there are different forms of eligibility. I mean, historically, we've had, different rules that says which groups in society are entitled to receive services and to be to establish a relationship with this side of the equation. And then there's all kinds of complex exchanges. For example, the population pays taxes to the state, has claims for services. They're organized politically and can claim. The state then organizes subsidies, information, technologies. The state then mediates, and some of these go to this side. And the picture is complicated because in addition to the health personnel, strictly speaking, any health system has a number of resource generators, like universities, that will take, for example, people from the population side, educate them, and then produce human resources for the health care part of the health system. Or it will take money from people and make it into payment mechanisms, and so forth. Resource generators are typically educational institutions that are dealing with the training of human resources, or research and development institutions like pharmaceutical companies and others that will produce technologies. And then lastly, there's other systems that fall outside of the primary intent boundary, like the education system, like the transportation system, like the agricultural system, that have an enormous impact on health. And this is where there's all kinds of complex relationships here. The collective mediator also, like it does with health care organizations, will have different degrees of control over the other set of institutions. The health organizations will be competing often for responsibilities and resources with other sectors of the economy. These are the source of the social determinants of health, so they have a direct impact on the health level of the population, and so forth. The population, of course, is organized, so through community participation, it interacts also here. It's not that the population only receives services or health actions, as we've called them, which are right here. It's also that in turn, the population participates in the organizations that provide care. If you look at the left side of this, these are the institutions. This is the institutional side of the health system. And it includes not just the health care institutions, it includes those parts of the government that are directly involved with health or that have an effect on health. And that, you were saying, well, what about the Congress, the legislature? Very much part, because although their primary intent is, in general, much broader, when they legislate on health, those actions are health actions because the primary intent is to improve health or do something to health, right? It includes the research generators, like universities, pharmaceutical companies, and so forth. And then institutions that are not within the health system, but that have this enormous effect through social determination are all these other systems. So this is the institutional side, this is the population side. And this is very different than most frameworks, which basically only take this side, and they define this. In fact, you would say this is typically, with maybe a few of this, the healthcare system, but even people who talk about the health system leave it maybe on this side, on the institutional side. And one important message for you is that the population is very much part of the health system, because the health system is this set of structural relationships. Now, think about people, because we talk about the population, but it's people. Why do I say that they are part of the health system? Well, people perform multiple roles, right? In the health system. They are, of course, patients, right? This is the way we most of the time think about people. They're, patient doesn't mean that you are very tolerant to delays. It means that you suffer, right? It comes from the a Latin root that means to suffer. You're the sufferer who has a health condition that somehow has been defined as a need, requires care, and you are there receiving that. But very often, people are not just patients, they're consumers. And therefore, they expect to be treated in a certain way, with certain promptness and courtesy and so forth, and to pay a fair price, whether individually or as a collectivity. So people are also the financiers of the health system, right? Whether a health system is funded through general taxes or insurance premiums or out-of-pocket payment, all that money comes from the population side of the health system. Institutions don't have, the collective mediator, the state doesn't have the money. It's the population, through its engagement in the economic system, that generates the ultimate, or that is the ultimate source of financing. Of course, people are also citizens, because we said they are organized. And they are citizens who may then construe access to healthcare as a right, and who then promote political participation through civil society or through political parties, so that the health system is organized in a certain way, and they vote for those parties and platforms that promote their own view about the health system. And then, very importantly, probably the most important role of people, they are co-producers of health, okay? So, contrary to other goods where, when I buy a car, I have nothing to do with the manufacturer of the car. Even some services, when I go and have my hair cut, that's it, I sit down, it's done to me. In health and in education, people are co-producers. They're co-producers, A, by their own belief systems that lead them to define some conditions as a need, then their behaviors in seeking care, then their behaviors in interacting and being compliant, and increasingly, as we saw last time when I was asking you what is new, in the determinants of health, several of you said the access to information, right? So in our era of access to information, this role as co-producers is actually enhanced or empowered, or when the information is inaccurate, like all the misconceptions about vaccines, then it can be misleading. But even in that case, people are co-producers. So when we talk about the boundaries and the actors, it's fundamentally important that we don't fall into the very common practice of just thinking of the health system as the institutional side. People are a key part of the health system, okay? And because they play at least those roles.